Time, I'd like to invite our first speaker, Dr. Aditya SUDHALKAR, who will be talking to us about tackling the uveitic cataract and the role of steroids, perioperative, in all forms in cataract surgery.
Yes.
Can we shift to the other podium? Thank you.
Thank you so much, Dr. Shell, and it's an honor to be here for this course. So I'll just start with a quick case illustration. So this was a 55-year-old male, a housewife, who came to us with sudden onset decreased vision and metamorphosis since 15 days, painless in onset. Yeah. She was a known case of diabetes type 2 with fluctuating control and family history of cataract surgery in the mother. The anterior segment examination was unremarkable except for the presence of grade 2 nuclear sclerosis. So this was her photo, and based upon this picture, she had been started on topical nepafenec eye drops, and a presumptive diagnosis of diabetic macular edema was made. The angiographic sequences, however, revealed early hypofluorescence along with patchy late hyperfluorescence, indicative of uveitis or specifically multifocal choroiditis. So these were the, for example, I think I'll just, as you can see, there are multiple patches of choroiditis here. So the patient was treated solely with a dexamethasone implant, and that showed near complete resolution within, say, a week or so of the injection. This was a recurrence that happened about 6 months later, and then a second implant was administered. Subsequently, she underwent cataract surgery, and with a third implant that was for prophylaxis, especially because she had already had 2 recurrences. So this is, uveitic cataract is obviously a technical challenge. We have recurrence, persistent, or new onset cystoid macular edema, epiretinal membrane formation. The incidence complication varies between 12 to 60%, and prophylactic immunosuppressive therapy is now the standard of care. So I would just like to cite our own study and discuss in some detail the entire proceedings. So this is a couple of articles related to uveitic cataract or post-cataract complications such as the Irvine gas syndrome, or what is popularly known as pseudophakic CME. So we have the MUST trial, which validated the use of steroids in, or local steroids, and specifically the intravitreal dexamethasone implant for management of intermediate and posterior uveitis, and to some extent even anterior uveitis. A cheaper alternative is triamcinolone, and 25%, a sample size with a approximate percentage of 25% prevalence and a power of 80%. That was our recruitment criteria, and a 6-month follow-up. So the purpose was to compare the safety and efficacy of intravitreal dexamethasone implant with systemic steroids as prophylaxis in patients with cataracts secondary to or associated with intermediate or posterior uveitis undergoing phacoemulsification with intraocular lens implantation. The trial was sponsored by Allergan India, now of course AbbVie India. So coming to the results, these are the demographic characteristics of both patients in both groups. So the trial was essentially divided into 2 parts. One in which the patient received solely the dexamethasone implant at the time of cataract surgery. In the other group, the patient received oral steroids starting 3 days prior to cataract surgery and extending up to a month after cataract surgery. So if you see, the improvement in vision is comparable in both groups, as you can see here. And most importantly, the cystoid macular edema was controlled in both groups. Most importantly, the dexamethasone implant group did not have any systemic complications. So we concluded that the Dex-I is non-inferior to systemic steroids in the management of uveitic cataracts. It is a good alternative in uncomplicated cataract surgeries, and it is a safe option for local therapy, which is generally preferred, and obviously it avoids systemic. So there are a couple of other articles or publications that we have had with international speakers, and all of them conclude more or less the same thing. the problem with the use of steroids in cataract is that everybody's apprehensive about IOP rise and cataract formation. Now, of course, if cataract surgery is being performed concurrently, one complication is practically eliminated. But as far as IOP rise goes, what we have seen is that as far as the dexamethasone implant is concerned, the IOP can be very well controlled with topical therapy. In a series of about 477 eyes that received dexamethasone implant for various indications, including diabetic macular edema, uveitis, and vein occlusion, only one patient or one eye needed a trabeculectomy. So overall, it is a very safe implant. In a price-sensitive market like India, the problem, of course, is the cost. And so the triamcinolone implant, the triamcinolone acetonide injection works very well. Now, the problem with triamcinolone acetonide, as we know, is persistent and a very steep rise in the intraocular pressure. And it is often, it extends much beyond what we would consider as the duration of efficacy of the injection. That is not the case with the dexamethasone implant. So in the dex implant, what happens is that even if the IOP does rise, it almost always touches baseline by the end of 6 months, which is the life cycle of the implant. That is not so with triamcinolone. And this is the reason why we, if affordability is not an issue, we prefer the dex implant. So this is just, our technique of injecting triamcinolone. And this is based on a study that we did, wherein we looked at the position of the dex implant, and what we saw is that the closer the implant is to the pars ciliara, the higher the chances of an IOP spike. The hypothesis is the entry of the steroid molecule in the anterior chamber is imperative for glaucoma occurrence. That is, the trabecular meshwork changes, increase in glycosaminoglycans and so on and so forth, happen more frequently with anterior position of the implant. Based upon that, what we do is we do a conjunctivotomy, a tenotomy, and then use a viscocannula to actually inject triamcinolone into the subtenon space. So what it does is, it has two advantages. One is where you are, and there is no inadvertent puncture of the sclera during the procedure. This is just a video on how to inject the dex implant at the end of cataract surgery. So you go in with the bevel down and you aim for the optic disc. So doing that, it helps you, direct the implant as posteriorly as possible. What we also noted is the surgeon removed the dispersive viscoelastic after the injection of the implant. Why dispersive? It will block the ports, the main incision and the side ports well enough, and there will be no squishing of the eyeball, because it's a big needle, it's a 22 gauge needle, and that is what we don't want to do. That is cause collapse of the globe. So again, some articles on the safety of the implant. Overall, it's a very safe procedure, and especially post-cataract, we have rarely, if ever, noted any IOP spikes. This is just from our article, and this patient received the implant. He had a uveitic cataract, and he got the implant prior to cataract surgery. And as you can see, this is flush with the pars plana. So this patient developed an IOP rise within 3 days of injection. So he came to us with an IOP of 37 with vomiting because of the sudden rise in IOP. So this is something that we want to avoid. As you can see, the implant is stuck in the pars plana. This is yet another case, another problem that we have seen with the dex implant is lack of familiarity with the procedure. And this was a surgeon who actually just punctured the conjunctiva. And you can see the whole implant is subconjunctival. So what happens is that, everybody's scared of the size of the needle. But just a few procedures and I think everybody's good to go. So the patient here came with a complaint that there has been no change after the injection, and obviously because the implant is not in the right position. So just to conclude that uveitic cataracts can be very readily managed and eminently managed with local therapy. It is a very good and viable alternative to systemic steroids. It can be supplemented with systemic steroids, of course, at any point in time. It lessens the incidence of post-operative systemic complications and even ocular complications. And if not the dex implant, there are cheaper alternatives available. Thank you very much for your attention.
Thank you so much, Dr. Aditya, for that wonderful presentation. And I think it's very important that if we can avoid any form of systemic complications during an ocular surgery, because that's what patients don't really expect, systemic complications to occur after a topical cataract surgery. I think that would go a long way in, improving our confidence as well in counseling the patients. I had just one question, Dr. Aditya. Because you showed the implant position makes a lot of difference in the intraocular pressure, how do we kind of assure that we are injecting in a proper way? Is it the distance which matters, or the way, the angulation at which you inject that matters?
Right. So I think the biggest rate limiting step, if I may call, is the fluidity of the vitreous. So if it is gel-like, then it will impede the progress of the implant posteriorly. If it is fluid, you might actually end up hitting the retina, and there have been instances of the implant hitting the retina and causing superficial hemorrhages. Some have even reported a break. So in a vitrectomized eye, sudden pressure on the applicator clip should be avoided, but in normal eyes, I think you should go in with full force. So that is one thing. But yes, of course, you can't really have total control over that. And just if I must just take half a minute, what we have seen is that in severe uveitis forms such as say VKH or even sympathetic ophthalmitis, the implant has an independent and often superior role to systemic steroids. So there have been instances where the patient has received, with sympathetic ophthal, has received intravenous methylprednisolone, 3 or 5 doses, and was put on oral systemic steroids thereafter. There was the lumpy bumpy choroid that we associate with, that did not disappear until we put in the DEX implant. So yes, I would rate it in some situations even superior to oral therapy. So.
And how quickly does this DEX implant start working? Because we are being a slow release implant, we are worried that if the early postoperative period after cataract surgery is not covered, then is there any relevance? So
yes, 24 to 72 hours. So
I
think
that
almost
quick it starts
yes,
acting.
yes,
Okay.
instantly. And in fact, in patients with pseudophakic CME or Irvine gas, they have been on topical nepafenac or for months, even years after. Some cases we have injected, and within 4 days there is complete resolution. So just again, one more point. It is there's an increasing trend of injecting anti-VEGFs for pseudophakic CME or Irvine gas. So just if you go back to the pathogenesis of the of Irvine gas syndrome, there is no role for anti-VEGF therapy. So it is purely inflammatory, and we have increasingly seen the retinal surgeons recommending anti-VEGF for pseudophakic CME. So that is something that I just wanted to clarify, that it is best to go with steroid, either triamcinolone or dexamethasone.